Hi, I'm Ashwin Basavraj. I'm Section Chief of Pulmonary Critical Care and Sleep Medicine at Bellevue Hospital Center in New York City, and Associate Director of our Bronchiectasis and NTM program at NYU Langone Health.
And my name is Dr. Julie Philly. I'm a professor of medicine in the Department of Pulmonary and Critical Care at the University of Texas Health Science Center at Tyler.
And we're happy to talk to you today about NTM lung disease, improving diagnosis, individualized treatment, and adherence. And the objectives of this talk is we're hoping to have the audience recognize the risk factors, symptoms, and underlying conditions associated with NTM lung disease to improve time to diagnosis, develop NTM lung disease treatment goals and communication plans based on individual patient factors and circumstances, identify practical approaches to support patient adherence and completion of evidence and guideline-based treatment strategies for NTM lung disease, and evaluate data that is emerging from various sources on NTM lung disease burden and treatment, and identify its potential relevance to current and future practice. So to start out, we're going to talk about an overview of NTM, infectious organisms, the disease manifestations, incidence in the US, and risk factors. We'll talk about impact on quality of life, comorbidities, and mortality. We're going to go over cases of nodular bronchiectatic MAC and cavitary NTM lung disease to highlight the differences in management between non-cavitary and cavitary NTM. And we'll discuss symptoms of NTM pulmonary disease. So to start off, we'll talk about non-tuberculous mycobacteria, or NTM, which is known to be environmental organisms. So the way I like to explain it to my patients is that normally NTM likes to live in stagnant water sources. So shower heads, humidifiers, soil, lakes, and rivers. It tends to be in municipal water systems. And it's very difficult to treat because it tends to form a substance called biofilm, which surrounds the NTM organism and makes antibiotics difficult to penetrate through that biofilm and attack the NTM organism. There's different ways to categorize NTM lung disease. The more common way is those that are slow and rapid growing, both microbiologically and clinically. Slow growing mycobacteria includes Mycobacterium avium complex, or MAC, Mycobacterium kansasi, and Mycobacterium zenopi. In the United States, MAC being the most common slow growing mycobacterium that we see. There are also rapidly growing mycobacterium, the most common one being Mycobacterium abscessus. These are just some of the common NTM organisms that are out there, but there are close to 200 species of NTM organisms, and that list is growing daily. And when we talk about MAC specifically, it's a complex of organisms that tends to be difficult to separate individual organisms out in the lab. Normally around 12 species, and the most common organisms that form the MAC complex are Mycobacterium avium, Mycobacterium intracellulare, and Mycobacterium chimera. But just know that MAC is a complex of organisms consisting of a number of different types of bacteria that get lumped into a MAC complex. And we're going to be talking predominantly about NTM pulmonary disease today, but there are different manifestations of NTM. There could be skin and soft tissue NTM infections, disseminated NTM. We saw that often during the HIV epidemic in immunosuppressed patients, lymph node involvement with NTM and other sites of organisms. But the predominant form of NTM is pulmonary. About 77% of NTM disease is pulmonary. And out of those pulmonary NTM, the most common infection being MAC. Now, the incidence is increasing in NTM, and there are different reasons for that. We know that the general population is aging, diagnostic capability is improving, and we're thinking about it more. So clinical suspicion is increasing, and those are all reasons why NTM incidence is increasing. And this highlights the increased incidence of NTM with the map on the left from 2008 and the map on the right from 2015, the darker blue states having a higher incidence of NTM. And you can see that there's been a higher incidence of NTM more recently compared to 2008. And what's also interesting is that the darker blue states are surrounded by water. So these these states that are in darker blue are coastal region states, Florida, Hawaii, New York, which tends to have a higher incidence of NTM. So Does it have to do with something, with the water supply that are going into these states? It's not exactly understood, but that is one theory on why these specific states have a higher incidence of NTM. And there's different risk factors for NTM. Most commonly, bronchiectasis, which can be from a prior pneumonia or infection, can lead to underlying structural lung disease, mucus stagnation, and chronic infections that could take advantage of that, most commonly NTM lung disease. There are other risk factors. There can be aspiration, reflux, sinus issues. There could be immunologic or genetic deficiency. So, for example, cystic fibrosis, primary ciliary dyskinesia, alpha-1 antitrypsin deficiency. There are immunosuppressive agents that can lead to an increased risk for NTM, most commonly TNF-alpha antagonists. There are environmental exposures that we mentioned earlier, so aerosolized water from hot tubs, shower heads, and other sources, soil. And there's host susceptible phenotypes that we know are associated with NTM lung disease. For example, slender individuals, possibly with a marfanoid body habitus, scoliosis, pectus excavatum, mitral valve prolapse. We don't quite understand why there's an association there with NTM lung disease, but we know that there is one. And these are all known to be risk factors for NTM. Now, we mentioned immunosuppressive agents increasing the risk for NTM. This was a study done by our colleague, Dr. Kevin Winthrop in Oregon, looking at TNF-alpha therapy in the rheumatoid arthritis population. We know that there's an increased risk for tuberculosis in patients that receive anti-TNF therapy, but this study also highlighted that there's an increased risk for NTM lung disease as well for patients with rheumatoid arthritis exposed to anti-TNF therapy. So it brings up the idea that in patients who receive immunosuppressive therapies, such as anti-TNF therapy, should we be thinking about NTM lung disease if they have symptoms, if they have CAT scans that are suggestive of it? Should we be concurrently treating the patients with NTM antibiotics if they are receiving anti-TNF therapy? Or should we be recommending alternative immunosuppressive agents? These are all questions we should be asking ourselves in patients with suspected NTM lung disease who are being considered for anti-TNF therapy. And we also know there's some data that steroids also increase the risk for NTM lung disease. There are a few case control studies, for example, one in Oregon and Washington that showed an odds ratio of 8 for prednisone use, and another case control study in California and Oregon suggesting that inhaled corticosteroids used to increase the risk for NTM. And the risk with inhaled corticosteroids was dose-dependent, both for oral prednisone and inhaled corticosteroids. So we know that inhaled steroids are a mainstay of treatment, for example, in patients with asthma and COPD. And in patients that do have that diagnosis, it is recommended to continue to inhale steroids for that population. But in patients that, for example, might be misdiagnosed with asthma, and if they have underlying chronic infections such as NTM, we should be asking ourselves, is it really beneficial for these patients to continue inhaled steroids, or are we increasing the risk of NTM by continuing the inhaled steroid use? And we also know that NTM can affect quality of life, morbidities, and mortality. There was a systematic review that highlighted a decreased quality of life, and that could be from chronic symptoms, frequent hospital stays and outpatient visits, and all the treatments that are necessary for patients with NTM that they have to do at home. That all can affect their quality of life. There's increased comorbidities. In this particular study, there was an unclear mortality risk due to the heterogeneity of groups, but in a separate study from Ontario, it did show that there was an increase in mortality in patients with NTM lung disease. Now, there's different disease profiles in patients with bronchiectasis and NTM. The most common one that's discussed is what's known as the Lady Windermere's phenotype. That tends to be middle or older females, Caucasian, who may be thin in body habitus. They may have underlying scoliosis, pectus deformities. They could have nodular and interstitial infiltrates on their CAT scan. They may be silently aspirating secretions, and that tends to lead to bronchiectasis in the right middle lobe and lingula. They may have what's known as bronchiolitis or tree and bud on CAT scan, which could be a sign of a chronic infectious process such as NTM. And this profile tends to be slowly progressive. There could be a different type of presentation, for example, in older males who are smokers with COPD. They could be more rapidly progressive, and they tend to have more aggressive disease on their CAT scan with possibilities of cavitary findings and fibronodular disease. There may be also other profiles. So, for example, hot tub lung or hypersensitivity pneumonitis for NTM, which can present as diffuse ground glass on CAT scan. And there's different studies that have highlighted the symptoms of NTM pulmonary disease. These are two studies. The one on the left is a cohort study with MAC patients. The one on the right is an online survey study with NTM patients, highlighting some of the symptoms that we do see in patients with NTM. We know that fatigue is a common symptom with NTM, and that could be just from the chronic infectious process, a chronic cough, phlegm, shortness of breath, night sweats. You can have hemoptysis with NTM, and that could be from the infection itself. That could be from the underlying bronchiectasis. That also could be from some of the devices that we're giving patients. So, for example, airway clearance devices sometimes also can lead to irritation in the airways and contribute to hemoptysis. And if that's the case, we often recommend holding airway clearance temporarily to help the hemoptysis subside. And weight loss also is a big symptom that's a marker for progressive lung infection. If patients are losing weight, that tells us that their infection may not be controlled, that they need to increase nutrition, and that we may need to consider antibiotics for their NTM lung disease. Now, there were recent guidelines in 2020 that were revised based on the original guidelines in 2007 on management of NTM lung disease. The diagnostic criteria remained the same on the 2020 guidelines, and that's highlighted here. To diagnose a patient with NTM pulmonary disease, a patient should meet three criteria. They need to meet clinical symptoms suggestive of NTM pulmonary disease, radiologic manifestations, so for example, nodular disease or cavitary opacities, bronchiectasis or bronchiolitis suggestive of NTM, exclusion of other diagnosis, and they need to meet microbiologic criteria of NTM. So with that, a patient should have 2 positive cultures of the same organism to meet a criteria for NTM. They can have a positive culture from a bronchial wash or lavage, or they can have a transbronchial biopsy or other lung biopsy from a surgery with histologic features of NTM, so for example, granulomas, along with the positive culture for NTM. So if a patient meets clinical, radiographic, and microbiologic criteria, then you have a diagnosis of NTM. So we're going to start with our first case, and this is a nodular bronchiectatic MAC case. This is a 67-year-old female who presents to our office with mild chronic cough. Her weight is stable. She has no hemoptysis. She does have a past medical history of GERD, a never smoker. She has some social alcohol use, and she works as a teacher. No known drug allergies, and her physical exam was notable for some rhonchi in her lower lobes. She had some blood work that was sent to evaluate for etiologies of bronchiectasis. She had an autoimmune panel that was sent. Her ANA was mildly elevated. Her rheumatoid factor was negative. She had quantitative immunoglobulins that were sent to screen for immunodeficiencies, which were normal. She also had AVPA screening with an Aspergillus IgE and a total IgE level, which was negative. An alpha-1 antitrypsin level was normal, and she had sputum cultures sent. Her bacterial and fungal sputum cultures were negative, and she had 3 AFB sputum cultures were sent, and 2 of the cultures resulted positive for MAC. This is a cut from her CAT scan, and you can see here that she has bronchiectasis in her right middle lobe and lingula, and she has some bronchiectasis and some mucoid impaction and bronchiolitis in her left lower lobe. So to decide on treatment with antibiotics for NTM, it's important to try to categorize patients on who has risk factors for progression of NTM and who has a likelihood of remaining stable with NTM lung disease. And these are 2 studies that highlighted that. The study on the left was close to 500 patients with MAC pulmonary disease that met ATS criteria. And in this study, the 500 patients, 2/3 of them progressed without any antibiotic treatment. However, about a quarter of those patients remained stable without antibiotic treatment. And out of those patients that remained stable, half of those patients spontaneously converted their cultures to negative. Similarly, the study on the right, about 550 patients with MAC pulmonary disease, 60% were treated with NTM antibiotics, 40% did not receive treatment. And out of those that did not receive treatment, again, half of those patients spontaneously convert their cultures to negative. So it's important to try to investigate which of the patients are likely to progress, and we may need to be a little bit more aggressive with antibiotic therapy, and which patients are likely to remain stable, and we have some time to consider whether antibiotics are indicated or not. And there are certain risk factors associated with progression in which patients may warrant antibiotic treatment. And some of these risk factors in which patients are likely to progress are male genders, older age, presence of comorbidities. So, for example, chronic reflux, aspiration, immunoglobulin deficiencies, low body mass index, if they have elevated inflammatory markers, anemia, hypoabinemia, if they have a high extent of disease. So, for example, if they have cavities on their CAT scan, they have a higher burden of infection and they're more likely to progress. If they're smear positive, they may be more likely to progress. And the type of species, so for example, rapidly growing mycobacteria, are more likely to progress. And these are all risk factors in which patients may progress, and we may need to consider treatment a little bit more aggressively. So the decision to treat, should really, we should really take into account whether patients have these risk factors for progression or not. So, for example, if patients have more virulent NTM, so for example, if they have rapidly progressive mycobacteria, if they have multiple risk factors for progression, they have cavities on their CAT scan, if they're smear positive, if they have a lot of symptoms, if they have poor quality of life, we may want to have a low threshold for starting antibiotic treatment in these patients. However, if patients have slowly progressive NTM, if they don't have many risk factors for progression, if they don't have cavities on their CT, they're smear negative, if they have very few symptoms and a good quality of life, we have some time before we can start antibiotic therapy, and patients may benefit from watchful waiting and potential non-pharmacologic strategies, which can keep the bronchiectasis and the infection at bay. And when we talk about non-pharmacologic strategies, there are different strategies. The most common one that we think about is airway clearance. It's helpful to help relieve mucus from these airways to try to reduce the inflammation and the infectious burden. And for a lot of patients without risk factors for progression, that may be all that's needed in terms of management of these patients. So in terms of airway clearance, we can think about positive expiratory pressure devices, high-frequency chest wall oscillation therapy. There can be different coughing techniques. So, for example, huff coughing, postural drainage, and mucoactive agents. So, for example, hypertonic saline can be used in conjunction with airway clearance techniques to help with mucus clearance. We also recommend good nutrition, keeping on top of their weight, exercising, and management of their comorbidities. So, for example, if a patient does have underlying reflux, aspiration, or sinus issues, you recommend controlling those factors to try to minimize the chance of further infection and inflammation in their lungs. Now, with our case, the patient, given that the patient had mild symptoms, had 2 cultures positive for MAC, but otherwise did not have many risk factors for progression for NTM, the patient was started on airway clearance alone at the start with nebulized hypertonic saline and a positive expiratory pressure device. She also underwent genetic testing to look for underlying comorbidities and etiologies of the bronchiectasis. So the sweat chloride test to screen for cystic fibrosis and a nasal nitric oxide test to screen for primary ciliary dyskinesia were negative. She was referred to a gastroenterologist for reflux management, and she continued on airway clearance therapy for 3 months. However, her symptoms did continue. She had a chronic cough, and she started to lose weight. She had about a 5.5 pound weight loss after 3 months of airway clearance. We did send sensitivities off for her MAC. These are sensitivities that are listed here, and we'll talk about the importance of these sensitivities, but know on this slide that the MAC for this patient was sensitive to clarithromycin and to amikacin. So with sensitivities here, and this is an important point, is that oftentimes when we send out susceptibilities for MAC, it gives us a list of antibiotics that show up on the report. But there's only been two classes of antibiotics that have shown to correlate with what happens in vivo and in vitro with the patient, and that's the macrolides and amikacin. And here we look at not just whether they're sensitive and resistant, but we look at the MICs of these antibiotics. So it's known that for macrolides, a patient with MAC is sensitive to the macrolide if they have an MIC of less than or equal to 8, and resistant if it's greater than or equal to 32. For IV amikacin, it's less than or equal to 16, and resistant if it's greater than or equal to 64. And for inhaled liposomal amikacin, the MAC is known to be sensitive with an MIC of less than or equal to 64, and resistant if it's greater than or equal to 128. So we should be looking really at the macrolides and amikacin to see if patients are susceptible to these antibiotics, and we also should be looking at MIC cut points to see if a patient is in fact susceptible to these agents. And when we talk about different regimens for MAC, it's important to classify whether a patient has nodular bronchiectatic MAC or if they have cavitary MAC. So for nodular bronchiectatic MAC lung disease, it's recommended that patients, if we do decide to treat with antibiotics, be started on a macrolide, ethambutol, and erythromycin. If they have mild to moderate disease, we tend to give these antibiotics 3 times a week. And the outcomes with this regimen has been shown to be just as effective as daily antibiotics with less side effects. However, if a patient has more advanced disease, if they have severe nodular bronchiectatic disease, or if they have cavitary MAC lung disease, we tend to be a little bit more aggressive with treatment. We still do the macrolide, ethambutol, and erythromycin. However, we'll do it with daily dosing, and we consider IV amikacin up front in these patients, particularly if they have severe lung disease. We tend to continue the IV amikacin for a few months, and we monitor for response to treatment, both clinically and radiographically, and we then can transition to inhaled aminoglycoside after if they are making clinical improvement. So with our patient, the patient given that the patient was developing symptoms and weight loss on airway clearance, it was decided that the patient should start antibiotics. The patient was started on rifampin, ethambutol, and azithromycin 3 times a week. Airway clearance was continued. However, she did develop mild nausea on the antibiotics, and with the nausea, medications were temporarily held until the nausea subsided, and then it was introduced sequentially with about 2 days apart. And we did recommend nighttime dosing, which also tends to help with minimizing nausea. Patients can take that at night and try to sleep off any sort of nausea that does develop with the antibiotics. After 6 months of antibiotics on this regimen, her cough did improve. However, her cultures did remain positive for MAC, and she did not have a significant change in her CT findings. Now, to help answer that, we do have some options for antibiotics in patients who are refractory to standard guideline-based treatment, or who are developing side effects to any of those antibiotics from the guideline-based treatment regimen. And here are some examples of antibiotics that we commonly reach for. So clofazimine is one of the antibiotics that we could use for refractory MAC lung disease. It does require an IND, and there's certain side effects that we monitor for: QTC prolongation, any sort of skin discoloration. Bedaquiline is another antibiotic. Again, can have QTC prolongation, but we can reach for in patients with refractory MAC. The oxylidinones, linezolid and tedezolid, and inhaled amikacin, both the parenteral formulation and more recently the liposomal formulation, which has been approved in patients with refractory MAC lung disease. as an option, especially if patients are culture positive after 6 months. So a little bit more about amikacin liposomal inhalational suspension. It is indicated for patients with refractory disease who are culture positive after 6 months. There's one dose that's recommended. You can consider inhaled bronchodilator use as a pre-treatment, especially if patients develop any sort of cough while using the inhaled liposomal amikacin. And we do recommend baseline and periodic audiograms on it, given the potential for hearing loss in patients who do take aminoglycosides. And this was a study that highlighted the use of ALIS, or amikacin liposomal inhalational suspension. This was the CONVERT study, which looked at patients who were refractory to MAC, meaning that they were culture positive after 6 months of guideline-based therapy. They were randomized to a group to either continue guideline-based therapy or to another group where they continued guideline-based therapy and they had ALIS added on to the guideline-based regimen, and they were monitored on treatment and then off treatment for months after that. And what the study found was that by month 4, in the ALIS plus guideline-based therapy arm, about 30% of patients converted their cultures to negative, compared to the guideline-based therapy alone arm, which had close to about 9% of patients that were culture negative by month 4. So because of this, the FDA approved ALIS as an option for patients with refractory MAC, and it is recommended in the guidelines for an option for antibiotic treatment in patients with refractory MAC. And there's been also sustainability and durability data recently that has been published, which has shown that in patients who take guideline-based therapy plus ALIS, they do tend, about 63% of patients converted their cultures to negative, and that was sustained during the treatment duration on antibiotics. And once they completed their treatment, about 55% of patients in the ALIS plus guideline-based treatment arm remained culture negative, compared to patients in just the guideline-based therapy arm. About 46% of patients remained culture negative. So it does have sustainability and durability in the ALIS plus guideline-based therapy arm. Now, we mentioned some side effects to monitor for. So for macrolides, there are GI side effects, hearing loss, hepatotoxicity. We do monitor audiograms on it and blood work to monitor for side effects. Occasionally, we do get EKGs to monitor for QT prolongation, especially if they're on other QT prolonging agents. With ethambutol, we do monitor for any sort of optic neuritis or potential neuropathies. With rifampin, cytopenias, GI intolerance, hepatotoxicity, amikacin, as we discussed, renal issues, ototoxicity, and with ALIS specifically, cough, shortness of breath, commonly dysphonia may develop, and we do recommend potentially holding treatment and restarting after symptoms subside, and most side effects do subside after the first month of treatment. Now, adverse reactions are common. These patients are recommended to take antibiotics for a prolonged period of time, at least 1 year of their first negative sputum culture, or 18 months total. And interruptions in treatments are common. So if drug reactions do happen, there are different strategies. We can hold antibiotics. We tend to restart it sequentially to try to identify the potential culprit antibiotic. And if a patient does develop side effects to a particular antibiotic, we could substitute that particular antibiotic with a different antibiotic. We want to educate our patients on possible side effects and instruct them to contact us if any side effects occur. And we want to obviously manage side effects appropriately and as soon as they occur.
Let's begin case 2. This is a 76-year-old female with persistent cough and fatigue that has a history of hypertension, some mild COPD, has been experiencing weight loss, and was diagnosed with MAC after 3 years of this chronic cough and fatigue that simply would not go away. This patient was started on azithromycin 500 milligrams, ethambutol 1,200 milligrams, and rifampin 600 milligrams 3 times weekly by a local primary care physician, and was told essentially there are no other treatment options. And she's taken these medications for about the past 6 months, but felt a little bit uncertain about her care and self-referred to your clinic as an expert. She has multiple sputums, at least 3, which remain culture positive for MAC. She is tolerating the medications on a daily basis. So at the beginning of treatment, here is a sample of the susceptibility testing. You can see that she was grossly positive, smear positive, positive on plate and broth, with susceptibility to the macrolide and amikacin with the MICs, both of 8. This is a picture of her CAT scan. You can see a CT image that revealed left upper lobe, pretty well circumscribed cavitary disease. Throughout the rest of her CT, however, there were no signs of bronchiectasis or other pulmonary findings. So again, thinking about our case, our patient with the left upper lobe cavitary disease, she changed her medications to azithromycin 250 milligrams, ethambutol 800, and rifampin daily. In addition, she underwent a PICC line placement with IV amikacin being administered 3 times weekly, with side effects being discussed. The patient had serial sputum cultures sent monthly with serial safety labs also checked. And despite this aggressive therapy of oral therapy plus the IVs, 4 months later, she returns to the clinic still grossly culture positive, and she had a repeat image, which was compared to her prior image. What you can see here is persistent cavitary lesion with actually thickening and a little bit more inflamed wall of this left upper lobe cavitary lesion. Well, let's talk about that. We've already alluded to the fact that we should absolutely treat these patients aggressively with oral therapy, which is given daily, in addition to intravenous aminoglycoside therapy, which can either be given with amikacin or intramuscular streptomycin, if that's a consideration. But you should also consider surgery in these patients, especially for the following reasons. If the disease is localized, if the drugs fail to convert the sputums to negative, if the patients don't tolerate medical therapy, or if you're dealing with a macrolide-resistant MAC patient. It should also be noted that at experienced centers, under an experienced surgeon, that there are very low mortality rates associated with this type of surgery. So again, do you treat them with surgery or do you continue them on medical therapy? In the 2020 guidelines, the recommendation in selected patients with MAC lung disease is that we suggest surgical resection as an adjuvant to medical therapy after expert consultation. The rationale for this has now been proven in multiple observational studies looking at a multitude of patients who underwent surgical resection whose outcomes were better compared to those patients that just underwent antimicrobial therapy alone. Cavitary disease is something that should be taken seriously. Outcomes are worse if you choose not to treat cavitary disease, and the use of injectable aminoglycosides can increase culture conversion. Again, we recommend daily oral MAC therapy over 3 times weekly therapy in cavitary disease, and we recommend the use of an injectable aminoglycoside, which can be IV amikacin or intramuscular streptomycin in addition to the oral meds. Naturally, you need to be cautious of side effects, and you need to use this in caution in patients with renal disease. And some experts would consider the use of inhaled liposomal amikacin under certain circumstances, but this is not proven with research that we currently have. It's also important to note that we employ a patient-centered, multidisciplinary approach. You need all hands on deck, which may include pulmonologists, infectious disease specialists, primary care, respiratory therapists, dietitians, thoracic surgeons, physical therapy, and of course, we cannot underestimate the importance of the lab. So we've been over nodular bronchiectatic patients. We've been over cavitary patients. What's new in the treatment of MAC lung disease? And there are things that are coming into play with new research trials and research studies. Some of these are new drugs like new antimicrobials or new formulations, but some are repurposed antimicrobials such as bedaquiline, clofazimine, and tedizolid. Other things are not antimicrobial, but rather anti-inflammatory and other pathways. We have some of these listed here. And then we are also reconsidering the use of bacteriophages and their implications in the treatment of MAC lung disease. Further studies will help us answer these questions. So in summary, patients with MAC lung disease need to be taken seriously. The incidence of these cases are increasing. Patients meet disease criteria, should pursue pulmonary hygiene and consider therapy. Recommended treatment includes oral therapy, azithromycin, ethambutol, and rifampin for 12 months beyond culture conversion. You can use 3 times weekly therapy in non-cavitary disease, but daily therapy is recommended for cavitary disease in addition to an injectable aminoglycoside. It is important to note that antimicrobial susceptibility is recommended as related to the macrolides and amikacin. Patients with disease refractory to standard therapy should be considered for the addition of amikacin liposome inhalation suspension, and that is always important for the patients to be educated, to actively monitor them, and to pursue a multidisciplinary approach to promote strategies which can improve tolerance and adherence, and that surgery is an adjunct therapy in selective cases. We appreciate your time today and your attention to this important disease topic.